All right, welcome. So you're getting ready for your big phlebotomy certification exam, right? Well, you are in exactly the right place. We're going to break down the absolute must-knows, the stuff that will help you walk into that test feeling totally confident.
Okay, so here's our game plan. We're going to tackle 4 really key areas, and we're starting with the most important one, the foundation of literally everything you do, specimen integrity. You know, it's so easy to forget this, but every single correct diagnosis, every single treatment plan, it all starts with the tube of blood you collect. Getting this part right isn't just a small detail. It's everything. So let's kick things off with a question you are almost guaranteed to see on your exam. You're looking at a tube of blood that's been spun down. You see that liquid on top? Is it serum or is it plasma? And more importantly, how can you be 100% sure?
Okay, the secret is all in the tube's additive. It's that simple. If you're looking at serum, it came from clotted blood. Think about your red tops or your gold tops. There's no anticoagulant, so all the clotting factors, like fibrinogen, got used up to make that clot. But plasma, that comes from a tube that does have an anticoagulant, like a lavender top. In that tube, all those important clotting factors are still floating around, which is precisely why you need plasma for coagulation studies.
And listen, this right here, this is one of the biggest trip-ups on the exams. Seriously. So let's just lock this in our brains right now. If the blood clotted, the liquid on top is serum. If an anticoagulant stopped it from clotting, the liquid is plasma. That's it. Don't overthink it.
So this table just lays it all out for us perfectly. If the doc orders a CBC, you're grabbing an EDTA tube, a lavender top, because you need that whole blood to look at the cells. If they need coagulation tests, you're reaching for that light blue citrate tube to get plasma. And for a ton of chemistry panels or immunology tests, you'll be using serum from a clotted tube. See the pattern? The additive in the tube is what decides the kind of specimen you end up with.
Okay, that makes sense, right? So now let's build on that. We've got the specimen down. Now let's focus on the person at the other end of the needle. Your technique just can't be the same for every single person, especially when you're working with patients who have blood disorders.
Being able to spot the signs of common blood disorders, that's not just extra credit. It's a huge safety skill. It's what tells you, hey, I need to do things a little differently here to protect your patient from things like extra bleeding or bad bruising. And of course, it helps you get that perfect specimen every time.
Let's look at 2 conditions that are basically opposites. First, you have an anemic patient. They're already low on red blood cells, right? So you have to be super careful about something called iatrogenic anemia. That's when we, the medical team, cause anemia by drawing too much blood. Your job? Keep that draw volume to a minimum. Now, flip that. A patient with polycythemia has too many red cells, making their blood thick. That can actually make them bleed more, so for them, you're going to want to keep that tourniquet time short and apply really good, firm pressure when you're done. Okay, now let's talk about major bleeding risks. If your patient has thrombocytopenia, that just means they have low platelets. Their body can't form that first little plug to stop bleeding. So what do? Your job is crucial here. Apply gentle but extended pressure. We're talking at least 5 minutes. Now, for a patient with something like hemophilia, a really serious clotting disorder, you absolutely need a green light from a clinician before you even attempt the draw. And you need to be ready to hold firm pressure for a long time, like 10 to 15 minutes, maybe even more. So here's the bottom line for your exam. You have to connect these dots. The test isn't just going to ask, what is anemia? It's going to give you a whole scenario. You'll have to read the clues, figure out the potential disorder, and then pick the right safety action and, of course, the right tube. It's all about applying the knowledge. And that leads us perfectly into our next section, coagulation. And let me tell you, this is the high-stakes part of the job. When it comes to coagulation testing, there is literally zero room for error. A patient's safety, especially if they're on blood thinners, is riding on your precision. So I've got a question for you. Think about all the things that can go wrong before a sample ever hits the analyzer in the lab. We call those pre-analytical errors. Out of everything you can think of, what is the single biggest mistake that will ruin a coagulation test? It's an improperly filled light blue top tube. A short straw, that's it. That one little mistake is the culprit behind so many bad results, and it can cause a doctor to dangerously mismanage a patient's medication. And here is the golden rule. the one you can never, ever break. The ratio of blood to anticoagulant in that light blue tube has to be exactly 9:1. This isn't a suggestion or a nice to have. It is absolutely non-negotiable if you want a valid result. So why is this ratio so critical? Well, here's how it works. The citrate in the tube prevents clotting by grabbing all the calcium in the blood. Then, in the lab, the tech adds a very specific amount of calcium back in to kickstart the clotting test. But if your tube is underfilled, you have way too much citrate for the amount of blood. So when the lab adds their calcium back in, the extra citrate just gobbles it all up. The result? The blood takes way, way longer to clot than it should have. And that's dangerous. A doctor sees that falsely high number and might think, whoa, this patient's blood is too thin, I need to lower their dose, putting that patient at a huge risk for a deadly clot. Okay, to really get a handle on the tests, you kind of need to know the lab's roadmap for how blood clots. We call it the coagulation cascade. Now, in real life, it's a bit more complicated, but for your exam, this model is key. Think of it like this. You've got two main highways, the extrinsic pathway, which we measure with a PT/INR test, and the intrinsic pathway, which we measure with an APTT test. Both of those highways eventually merge into the common pathway, and that's where the final solid clot gets formed. Okay, everyone, lean in close for this one. This right here is pure exam gold. You have to memorize these pairings. Let's say it together. PT/INR goes with the extrinsic pathway and monitors warfarin. The APTT goes with the intrinsic pathway and monitors heparin. If you mix these up on your test, you're just giving away easy points. So burn this into your memory. All right, let's bring it all home with our last section. This is where everything we've talked about really comes together. Because being a great phlebotomist isn't just about being good at finding a vein. It's about being safe for the patient, for the specimen, and for yourself every single time. These are your absolute non-negotiables, the OSHA rules. You wear gloves for every single draw. No excuses. The second that the needle comes out of the arm, you activate the safety device. Immediately. You never ever recap a needle. These aren't suggestions, they're rules designed to keep you and everyone else safe from really serious infections. Okay, let's talk about a real-world situation you're going to face all the time. You walk into a patient's room, ready to do a draw, you look at their arm. What are the red flags that make you say, nope, this arm is off limits? So here are your biggest no-go zones. First, an arm on the same side as a mastectomy. Absolutely not. There's a huge risk of infection and a painful swelling called lymphedema. What about an arm with an IV? You can't draw above the IV line. Why? Because you'll just be sucking up all that IV fluid. The lab won't be testing the patient's blood. They'll be testing saline, which will dilute everything, or glucose, which will give a crazy high sugar result. Same goes for a swollen edematous arm. You're just drawing tissue fluid. And a hematoma or a big scar? It's painful for the patient and gives you an old, useless sample. The bottom line is you always have to check out both arms before you even think about sticking. I really want this idea to stick with you because it's kind of the whole philosophy of being a great phlebotomist. The results that come out of the lab should reflect the patient, not the procedure you performed. Everything you do, your technique, your knowledge, following all these rules, it's all to make sure that the numbers tell a true story about what's happening inside that person, not a false story created by a mistake during the draw. So as you keep studying, I want you to ask yourself this question with every practice draw, with every chapter you read. How can you make sure that every single draw you do leads to a result that's totally defensible? Think about it. From the moment you ID the patient to the second you label that tube, every action you take builds that final, accurate result. That's the goal. That's excellence. You are totally going to crush this. Good luck.